Welcome everyone to our webinar today, Breast Cancer and Bone Health, Pathways, Study Findings, and Clinical Recommendations. This is our fifth in the Pathways Breast Cancer Survivorship series, and we're so glad you could join us today. Before we begin, I want to make sure that you know that slides are on the website. Kaiser Permanente's Janice Rowe is helping out today by putting links in the chat, and she will do so for the website with the slides. Also, the webinar is going to be recorded, and it's going to be emailed to everyone who registered, so you will get a copy of that. There's also a live transcript or captioning available that you can find at the bottom of your screen. The chat is disabled for participants, but you can all answer or ask questions in the Q&A box at the bottom of your screen. So feel free to ask your questions as we're going through the webinar today, and then there will be a section at the end where we will all join to answer questions together. It's an hour-long webinar, and some of us may be able to stay a little bit longer to answer some more of your questions. Dr. Amber Wheeler, unfortunately, might have to leave around 1 p.m., so we'll ask the clinical questions first so that you can get more of hers answered. Yeah, let's start the webinar. So I am your moderator, Leanna Hartmore, and I'm Zero Breast Cancer Program and Communications Director at Collaborative for Health and the Environment. We've spent 28 years bridging communities and researchers and creating educational resources for kids through adults to reduce the risk of breast cancer and support survivors' health and wellness. We also have a health and wellness coaching program for breast cancer survivors after active treatment, and Janice is going to share that link in the chat. She's also going to share the link to sign up for our emails to learn more about our resources and programs. Before we begin, I want to give a shout out to our Pathways Survivorship Study Community Advisory Board members. This is a team facilitated by Zero Breast Cancer and Kaiser Permanente, research participants in the Pathways study that give input into the research design and priorities, community education, and they all contributed to giving feedback on the webinar today. So you can learn more about the Pathways study at the link in the chat. I'm going to pass it on to our first speaker, Marilyn Kwan. She is a research scientist at Kaiser Permanente Northern California Division of Research, and she's been a co-investigator on the Pathways study since its beginning and focuses on many aspects of breast cancer survivorship research, including fractures, lymphedema, cardiovascular disease, cancer recurrence, and quality of life. So I'll pass it to Marilyn now.
Great. Thank you, Leanna. My screen. All right. Hello, welcome to our community forum. As Leanna mentioned, I'm Marilyn Kwan, a research scientist at the Division of Research and a co-investigator on the Pathways study. I'm happy to be here today to talk about our research on bone health in breast cancer survivors. As many in the audience know, following a diagnosis of breast cancer, patients undergo a series of treatments to treat and cure their disease. Some might start with surgery, and some might start with chemotherapy. This slide shows the typical sequence and duration of multimodal breast cancer therapies. Patients start at the top of the cascade, and depending on the type of tumor and the stage of their breast cancer, as well as their own personal preferences, they may receive some or all of these treatments, typically in the order they are shown here. The approximate duration of each treatment is shown by the arrows. The usual last treatment in this cascade of therapies is endocrine therapy, which can last from 5 to 10 years after the breast cancer diagnosis. So how does endocrine therapy, or otherwise known as hormonal therapy, treat breast cancer? It works in two ways. First, it can block the hormones from attaching to the receptors on the cancer cells, and prevent their growth. Second, it can decrease the production of specific hormones in the body. Hormonal therapy for breast cancer is effective only if it has receptors for two important hormones. These are estrogen or progesterone. For breast cancer, we call this ER-positive or PR-positive tumors. Lowering the production or preventing the attachment of estrogen on breast cancer cells can help treat breast cancer. There are two types of hormonal therapy. The first is selective estrogen receptor modulators. The most common SERM is tamoxifen. And the second type is aromatase inhibitors. And these drugs include anastrozole, exemestane, and letrozole. So now I'd like to spend a few minutes discussing how hormonal therapy works to treat ER or PR-positive breast cancer. This slide shows how SERMs, or tamoxifen in this case, works. On the left side of the slide, we have a typical breast cancer cell. Normally, estrogen, shown here, binds to its receptor in the breast cancer cell. But once, however, when you introduce tamoxifen, tamoxifen binds to the estrogen receptor and effectively blocks estrogen activity, as shown here, thus stopping the growth of the breast cancer cells. Tamoxifen is typically prescribed to both premenopausal and postmenopausal women. Now, this slide shows how aromatase inhibitors work. Normally, in a fat cell, androgen, a hormone, is converted to estrogen through the work of an enzyme called aromatase. When somebody has aromatase inhibitors, when an AI is introduced, the aromatase inhibitor stops aromatase, the enzyme, from converting androgen to estrogen and effectively lowers the circulating estrogen levels in the body. And this in turn hinders the growth of breast cancer. Unlike tamoxifen, aromatase inhibitors are typically prescribed to postmenopausal women. So because of this rapid depletion of circulating estrogen caused by aromatase inhibitors, women on these drugs have an increased risk for osteoporosis and fractures. AIs have numerous benefits. They are very effective in treating breast cancer in postmenopausal women with hormone receptor early stage breast cancer. However, there are side effects. And aside from osteoporosis and fractures, women can suffer from muscle pain, joint pain, hot flashes, vaginal dryness, and cardiovascular disease. Regarding osteoporosis and fractures, studies have shown that bone loss related to aromatase inhibitors can be more rapid than bone loss associated with menopause, and the severity of the bone loss can increase with the duration of treatment. So given this background on the negative impact of aromatase inhibitors on bone health, we launched the Pathways Bone Health Study back in 2012, funded by the National Cancer Institute. We had two major aims. They were, first, to examine the incidence of osteoporosis and fracture in women on AIs for their primary breast cancer. And second, to investigate how lifestyle, molecular, and genetic factors might influence risk of osteoporosis and fracture. In terms of how we designed this study, the Pathways Bone Health Study is embedded within the larger Pathways prospective study of breast cancer survivors. The Bone Health Study is a group of women identified from the larger Pathways study, about 2,100 women diagnosed with HR positive, that is ER positive or PR positive breast cancer, diagnosed from 2005 to 2013, who started an aromatase inhibitor for their hormonal therapy. We then collected bone mineral density, BMD measurements from their DEXA scan reports available in the electronic health record. We obtained measurements at the femoral neck, total hip, and lumbar spine. Subsequently, we followed women for occurrence of new major fractures after the initiation of aromatase inhibitors. These fractures were confirmed in the electronic health record by our study endocrinologist. The four major fractures of interest were at the humerus, which is the largest bone in your leg, the wrist, hip, and spine. In terms of how long we followed women for these fracture outcomes, the median follow-up was about 6 years. We followed women from less than 1 year to almost 10 years from their breast cancer diagnosis. For today, I'd like to present study findings from one article we published back in 2021. It is an analysis of the influence of lifestyle factors on risk of osteoporosis and fractures. If you'd like to read more about the study, you can go to the link shown here, and Janice will also be pasting it in the chat. So this slide shows characteristics of the bone health cohort included in our analysis. On the left side, you see a few characteristics of the over 2,100 women included in our study. The vast majority, as you can see from this top pie chart, were prescribed and started anastrozole, while a much smaller proportion, about 15%, began letrozole or exemestane for their aromatase inhibitor therapy. The average age at diagnosis, as depicted by this pie chart here on the left, on the bottom left, was 63 years at the time of the breast cancer diagnosis, and most women, accordingly, were postmenopausal. On the right side of the slide shows the women who eventually developed or experienced a fracture over our follow-up period. There were a total of 165 women, about 8%, who had an incident fracture after starting on their aromatase inhibitor. Unlike the entire cohort shown on the left, those who had a fracture were older when they were diagnosed with breast cancer. The average age was 69 years. And interestingly, the slightly more, though not statistically significant, took letrozole. So our study that we published focused on lifestyle factors. And one lifestyle factor I'd like to speak about today is physical activity. In our analysis, we asked the question, how do modified lifestyle factors like physical activity impact fracture risk in our cohort of breast cancer patients on aromatase inhibitors? We asked women enrolled in our study to complete a physical activity questionnaire, reporting on their usual physical activities, including the type, duration, and intensity of their exercise. Some important findings that we arrived at were that women engaging in less aerobic exercise, that is less than 150 minutes per week, which is the recommended national guidelines, so 2.5 hours, at least 2.5 hours per week of aerobic exercise. These women, during the 6 months after their diagnosis, had more than twice the risk of having a fracture over the next 6 years. In addition, we found that women who had none or infrequently engaged in moderate to vigorous physical activity during the 6 months before their diagnosis had nearly twice the risk of osteoporosis. So what does this mean? Well, we can confidently say that physical activity can be recommended for osteoporosis and fracture prevention in women on aromatase inhibitor therapy. We've also published other research findings from the Pathways Bone Health Study, as shown here on this slide. These analyses included the influence of bone biomarkers on the risk of osteoporosis and fractures, as well as the impact of genetics, this polygenic risk score, on the risk of osteoporosis and fracture. For the last part of my talk, I'd like to take a few minutes to describe our final goal of the bone health study. This goal is to develop a fracture risk prediction model for breast cancer patients eligible to receive an aromatase inhibitor. Our plan is to create a prediction model based on factors found to be associated with fracture risk in our prior analyses, including patient demographics, clinical characteristics, genetics, circulating biomarkers, and bone density results. This slide shows the FRAX, which is short for the Fracture Risk Assessment Tool, which some of you might be familiar with. Currently, the FRAX is used in the clinic to calculate the 10-year chance of getting a fracture in healthy adults after taking into consideration multiple characteristics of the patient, such as age, sex, weight, height, previous fracture, smoking, etc. So after one inputs this information in the FRAX calculator, you click Calculate, and then 2 scores are automatically outputted, indicating your probability of having or experiencing any major fracture or hip fracture over the next 10 years. The higher your score, the more likely you'll get a fracture. So like the FRAX calculator, which I just explained, we'd like to create a risk calculator for women eligible for an aromatase inhibitor. How it would work is like this. The breast oncologist would input the required information on a patient who is eligible to take an AI for hormonal therapy, and then a probability score would be outputted. This information will be used to help guide and inform the discussion with the patient to decide whether or not to initiate AI therapy. So after we develop this breast cancer FRAX, we plan to collaborate with our KPNC, our Kaiser Northern California oncologists, to pilot this at regional breast clinics. Our goal would be twofold in collaboration with our clinicians. It would be first to implement this BC FRAX to support clinician-patient decision-making around AI initiation, and second, to evaluate its performance to predict short-term fracture risk. Our ultimate goal is to improve how long-term health in our breast cancer patients can be improved. So on that final note, I'd like to say thank you for your attention, and I'm happy to take questions during our Q&A portion of our webinar.
Thank you so much, Marilyn. I would like to introduce Amber before handing it over to her. So Dr. Amber Wheeler is a general endocrinologist at Kaiser Permanente San Francisco Medical Center. She's the Medical Center Regional Clinical Lead for Falls and Fracture Prevention and is the San Francisco Osteoporosis Champion and Clinical Lead for Fracture Prevention Service. She's on the core faculty for the Kaiser Permanente San Francisco Internal Medicine Residency Program, focusing on diversity, equity, and inclusion, resident mentoring, and career development and subspecialty education. So I'll pass it on to her. And don't forget to put your questions in the Q&A as they come up.
Thank you, everybody, for inviting me to come speak today. Speaking about bone health and osteoporosis is one of my clinical interests, and I'm so honored to be invited to speak to all the participants and also to join these amazing panelists today. So thank you so much for inviting me. My name is Dr. Amber Wheeler, and as Leanna mentioned, I'm part of the Department of Endocrinology at Kaiser Permanente in San Francisco. And today I'm going to talk to you about protecting your bones and an approach to bone health. All right, so the first thing is that your skeleton is actually a dynamic organ. Your bone health is going to be evolving throughout all the various stages of life. What's going to be regulating your skeletal health will be a balance of 2 different cells that are in your bones. One is going to be your osteoblasts. These are the bones that are, these are the cells within your bones that help you to form the bone that you're making. And then also in balance with the other cells called osteoclasts. And these, at various stages of your bone health, these cells will be at different stages, and they'll be either working to help you to rapidly build bone, or in some stages actually contributing where you're maybe noticing a decline in bone health. So as you can see here, during puberty and also early stages of adolescence, you're in a stage of very rapid bone building, majorly geared by the osteoblast building bone. For most patients, they hit their peak bone density sometime around age 30. And there's an area here where the osteoblasts and osteoclasts are in somewhat a balance with one another, and they're maintaining this bone mass. However, around age 40 to 45, around age 40 to 50, as women are going through the menopausal transition, you can start to see that there is a decline in the bone density over time that persists even into the older years. So we want to make sure that we're focusing on helping patients to get to their peak bone mass so that they're entering the second stage of life at a really high level, and also trying to see what we can do to mitigate bone loss that may be happening during menopause. So what is osteoporosis? I just wanted to ground everybody in a definition that we use here. So osteoporosis is a skeletal disorder that's characterized by compromised bone strength, predisposing to an increased risk of fracture. So bone strength is a combination of your bone density plus your bone quality. So on the picture on the left here, you can see that this is a normal bone. You can see that the participant here has very strong bone mass, and you can also see that there's a very intact channels here between the different pieces of the bone. On the other hand, in osteoporosis, you can see that there's a lot of thinning to the bone or loss of bone mass, and you can start to see that there's a deterioration of the architecture of the actual bone, leading to fragility and loss of bone quality. So you can see that a lot of these changes that happen over time predispose patients to having fracture in these areas that are more vulnerable as the bone is being lost with time. So what are factors for developing osteoporosis? First, it's age and gender. As people get older, their bone density will naturally decline with time. I tell patients that if for anyone who lives long enough, we will likely see osteoporosis at some stage of life. Also, gender. For women, as they go through the menopausal transition and they start to lose the protections of estrogen on their bone, they can start to see a decline in their bone density as well. Men also are at risk of developing osteoporosis, but they do tend to develop osteoporosis at a later stage in life. So our screening recommendations are different for men versus women. Family history and genetics. So for women who have a family history of osteoporosis, they also are more likely to develop osteoporosis with time. Also, you can inherit different geometry of your hip. So if one of your parents had a history of hip fracture, you might be predisposed to also having a hip fracture later in life as well, too. There are many genetic factors that we think contribute to osteoporosis, but the genetics of osteoporosis are not really well understood. Next, we have lifestyle factors, things like diet, physical activity, and history of smoking and alcohol use. Diet is one component where if you don't have a lot of calcium exposure at especially earlier stages of life, when you are meeting your peak bone density, that can put you at risk of having lower bone density at later stages of life. For those who aren't as physically active, they may not build up a nice peak bone density or might be at risk of losing bone density or having falls or fractures. And different factors from smoking and alcohol use can also be associated with bone loss or also not hitting that peak bone density. Conditions associated with estrogen deficiency. So this may just be associated with menopause or going through the perimenopausal transition. But for a lot of our patients who have breast cancer, as Marilyn mentioned, many of the treatments for breast cancer, the way that they impact the body is that they do cause an estrogen deficiency. So this can be associated with more rapid bone loss or earlier bone loss developing osteoporosis. And then finally, we have medical conditions and medications that weaken bones. This may include medical conditions that are associated with inflammation or conditions that may need to be treated with medications that can lead to bone loss. These might be medications such as steroid treatment, or anti-seizure medications that may impact how you absorb calcium and vitamin D. So if you have any of the risk factors that are on this list, it's always good to make sure that you're following very closely with your healthcare provider so that we can make recommendations for when is the appropriate timing for you to be screened for osteoporosis. So why is it important to consider your risk for osteoporosis? First, osteoporosis, it's very common, but moreover, fractures are actually very common as well, too. So 1 in 2 women over age 40 will break a bone from osteoporosis in her lifetime. So I think this is so important to stress that as women get older, the risk of fracture starts to rise as well. And we want to do everything we can to try to prevent or lower the risk of having these falls and fractures as women age. And 2, also, a woman's risk of breaking a hip is equal to her combined risk of breast, uterine, and ovarian cancer. We do a lot of discussion about the different cancer screening and making sure women are up to date with their cancer screening. However, that I also want to emphasize the importance of making sure that you're up to date with your bone density screening as well, because we want to try to see if we can make sure that we lower patients' risk of having these hip fractures, which are associated with significant morbidity and mortality, especially as people age. So what can you do for your bone health? First is that we want to optimize your calcium and vitamin D intake. We want to make sure that you're prioritizing getting calcium and vitamin D through your diet, and if needed, through supplementation. Also, as Marilyn also mentioned, there's a very strong impact of being physically active and doing exercise on your overall bone health. So we emphasize doing not only aerobic exercises, but also making sure you're integrating weight-bearing activity and resistance exercise to your regimen. Also, we recommend maintaining a healthy weight. Patients who are underweight are actually at higher risk of developing osteoporosis or losing bone over time. So we want to make sure that people are getting appropriate nutrition and maintaining healthy weight. If you're smoking, we want patients to stop or start working with their providers to take the necessary steps to stop smoking. And also we want our patients to drink in moderation. Not only are the effects of alcohol and smoking deleterious to your bone density, but for instance, higher alcohol intake could be associated with falls risk, placing patients at risk of having fracture. Also, screening for osteoporosis or osteopenia when recommended. And I will go through the screening recommendations later on in the talk if patients have specific questions. And then finally, considering treatment for osteoporosis if indicated. What foods are rich in calcium and vitamin D? So calcium can come both from dairy sources and also non-dairy sources. So, milk, cheese, yogurt are all very rich in calcium. But for those patients who are either lactose intolerant or opt to go more plant-based, there are a variety of sources for calcium beyond just our animal-based milk products. So these might include dark leafy greens such as kale, broccoli, bok choy, or collard greens. Many other foods are also fortified with calcium, such as our cereals and also orange juice. Nuts and also chia seed are also foods that are high in calcium as well. But what about vitamin D? Our main source of vitamin D is actually from the sun. However, many people are often wearing sunscreen or indoors during the daytime and don't often get optimal sun exposure. So we also want to emphasize the importance of getting foods that are rich in vitamin D through your diet as well. This includes some of the fattier fishes like salmon or canned sardines. Also, mushrooms. Actually, mushrooms that have been exposed to UV light are actually high in vitamin D as well. Many dairy products, and there are a variety of foods that are actually fortified in vitamin D as well, including cereals and also, as I mentioned, the orange juice. So it's always important to look at the labels to make sure that you're getting some adequate calcium from your diet, because I think that we have to be pretty intentional about making sure that that we are eating foods that are rich in calcium and vitamin D. But what are the recommended amounts of calcium and vitamin D that throughout the different stages of age? So from about age 20 to 50, we recommend getting about 1,000 to 2,000 of calcium through diet and supplementation. The 2,000 is the upper limit. So when I often get questions about how much calcium is too much calcium, I usually recommend getting less than 2,000, but making sure you're getting somewhere in this range. Most people would benefit from being on vitamin D supplementation. 600 at the earlier stages is very reasonable, but for some people in the, like for instance, in the Bay Area or where there may not be as much sun exposure, people often need to be on as much as 1,000 to 2,000 international units to hit their recommended vitamin D levels. Your calcium requirements will increase with age as well. So at around age 51 to 70, we recommend increasing from about 1,000 per day to about 1,200 per day. And again, the upper limit still remains at about 2,000 even as we get older. We still recommend starting with about 600 international units of vitamin D. But again, after people are older than 70, the requirements increase to about 12,000 milligrams per day and also about 800 international units. And if it's difficult to get enough calcium in just through your diet, we do recommend adding supplemental calcium. So the calcium that's available is calcium carbonate and calcium citrate. Those are the most two that are readily available on the market. And it's always good to look at the labels on the calcium supplements just to make sure how much of the calcium supplements actually contains active calcium that your body's absorbing and using to maintain your bone health. And just to piggyback on Marilyn's comments about exercise, as she mentioned before, the general recommendations for adults is that most people should aim to exercise about 30 to 40 minutes, 3 to 4 times each week, with some weight bearing and resistance exercise in the program. For our patients with osteoporosis, though, not every exercise is made similarly. So certain types of movements and exercises may not be suitable for people with osteoporosis, especially if you have osteoporosis in your spine or have a history of spinal fracture. We want to avoid excessive bending and also twisting. So sit-ups and bending at the waist may not be appropriate for you. Also twisting and movements such as a golf swing or some of these yoga poses that I put over in this column might be some to definitely to avoid. And also exercises that involve abrupt or explosive movement or really high impact loading. What's really important with exercise is that it always is good to consult with your physician before you start any exercise program. Also, if you're working with a trainer or you're in a program, it's really important to make sure that you alert them that you do have osteoporosis. Many yoga instructors or Pilates instructors are also well-versed in how to modify many of the movements for patients with osteoporosis. Additionally, when you're doing any weight-bearing or resistance exercises, such as lifting weights at the gym, many of the trainers can also be very helpful in these scenarios because they can help you to make sure that you're maintaining a neutral spine and avoiding a bending at the inappropriate site to put you at risk of injury. I love this particular website. This is the Two Fits or Fracture, and this is an exercise program that comes from actually the Canadian government. It has a lot of really informative videos on how to do strength resistance exercise and adding weight-bearing activity. And also it provides a lot of different clinical scenarios for when exercise could be modified and also what might be appropriate at various stages of life and actual different stages of fitness. And I've enclosed the link here if you want to take a look at the different resources that are available. There are also a lot of other resources available on YouTube or also through your medical provider. For instance, for my patients at Kaiser Permanente, we have a lot of online PT courses for our patients with fracture and also videos that are available too for people who want to learn more about how to be physically fit while having osteoporosis. So the next question we get is, how do we screen for osteoporosis? So you can see here, this is a patient who's sitting in a DEXA machine. And you can see that there's an arm here that's taking an X-ray of the patient's lower spine and also hip, so we can best evaluate the amount of bone density that's at these particular areas. So the DEXA machine gives us images like this, and you can see that the areas that we are imaging are areas that are particularly vulnerable to fracture for patients who have osteoporosis. On the hip side, we focus on two particular areas, the total hip and also the femoral neck. So this whole area here is the full total hip. And more specifically, we look also at the femoral neck, which is this portion of the hip right here. And the reason we look often at the femoral neck is that this is a very vulnerable site where if patients have a fall, this may be an area where they do tend to have their fractures. Next, moving over to the spine, we actually image the lumbar spine, or actually the lower part of the spine. And we look at the last 4 vertebrae. So this is a lumbar spine level 1 through 4. And we're looking here at the total bone density at these 4 levels. So when patients come in for DEXAs, we actually get a report like this. This is what the bone density report looks like, and it's going to give us a number of measurements. And a lot of times this can be really confusing as people are looking at it to be like, well, what are the areas that I should be focusing in on, and how do I interpret this when I go in to get these, when I go in to get my imaging? First, this is looking specifically at the hip. It's going to give us different regions. And as I mentioned before, we're looking most specifically at the neck and also at the total hip. First is that this is going to be your bone mineral density reading. So this is going to be the amount of mineral that's in these particular areas that we just highlighted. We take that bone mineral density, and when we plot everybody's bone mineral density, everybody kind of falls on a normal distribution. And when we start to interpret the bone mineral density, we're going to start to look at it in comparison to different populations. So next, we get something called a Z-score. And a Z-score is actually a standard deviation. So if I was comparing your bone density to somebody who is in the same age and demographic as you, how many standard deviations would your bone density be relative to someone who is the same age and ethnicity as you? And for this patient, they're actually pretty close to somebody who is the same age and ethnicity as them. However, we also get something called a T-score, and this is actually the important piece to look at on the bone density report. The T-score is actually a comparison between the patient and also somebody who's at their peak bone density. So for somebody who's at age 30, how many standard deviations are you below or relative to somebody who is at their peak bone density? And so this is how we actually define osteoporosis, is looking at these T-scores. So we define a normal bone density as somebody who is within one standard deviation below a person at their peak bone density. So with a T-score that's greater than or equal to one standard deviation, or -1. When we define low bone mass or osteopenia, when the T-score is between -1 to -2.5. And then finally, we define osteoporosis when that T-score is -2.5 or less. And the reason why we use this particular number here is that in our research studies, this is where we see that participants are at increased risk of developing a fracture when the T-score is actually below this range. When should you be screened for osteoporosis? So our recommendations for general screening for the general population is that we want to screen women who are postmenopausal, who are age 65 and older. We may opt to screen earlier for osteoporosis if you have a history of a fragility fracture. We define a fragility fracture as a fracture that's occurring with a fall from equivalent of a standing height or less. We don't expect that most patients will have a fracture if they fall from a standing position. So we do think that there must be some degree of fragility that's involved if patients sustain fractures like this. We may consider doing bone density screening for women who are under age 65 if they have any other risk factors for developing bone loss. So this may be medications, other medical conditions, family history. If you are maintaining a low body mass, so this is for a woman who is 127 pounds or less, or has a BMI that's less than 21. As I mentioned, this is the important one, is that if you have a family history of hip fracture, again, you might be at higher risk of having a hip fracture yourself. So we may want to start screening at an earlier age. And also if there's a history of smoking. So I'm going to also, to parlay on the secondary causes, oftentimes some of the elements attached to treating breast cancer may put participants at increased risk of developing osteoporosis. So breast cancer treatments can significantly impact bone density by causing bone loss and increasing the risk of osteoporosis and fractures. Many of the treatments reduce estrogen levels, such as using a treatment with an aromatase inhibitor, and can impact the vital role of estrogen in maintaining bone strength. Other therapies, such as steroids, are often given with chemotherapy agents and negatively impact bone health. And also some of the treatments can also cause early menopause, which can also impact how people meet their peak bone density and may put them at earlier loss than they normally would experience if they went through menopause at the time their body intended. So what treatment options do we have for people with osteoporosis? Osteoporosis treatments fall into two different categories. The first one is anti-resorptive medications. These are used to slow down bone loss. And then the other category is these anabolic medicines, and these are used to help to build bone. And we might choose medications in either category based on patient's medical history and what's appropriate based on the bone mineral density. However, both of these categories of medications do show significant improvement in lowering risk of developing a fracture. In some, it can be reducing the risk of fracture by up to 40 to 60%. So these medications are actually quite impactful and are very important parts of many patients' treatments. More specifically, for these anti-resorptive agents, we use a category called a bisphosphonate. And many of the common ones that people may be familiar with may be Fosamax or alendronate, Reclast or Zometa, or zoledronic acid. Denosumab, or the brand name Prolia, and then finally raloxifene. Raloxifene goes by the name of Vista and actually is in the same class of medications as tamoxifen. Okay, so in conclusion, osteoporosis is actually very common and impacts about 20% of women in the United States, where the prevalence increases with age. It's never too early to start thinking about your bone health and thinking about going through the list of things that we talked about, such as optimizing your calcium and vitamin D, being physically active and making sure you're incorporating in strength building and resistance exercises. If you're smoking, thinking about quitting smoking, moderating your alcohol intake, and thinking about either getting treated or screened for osteoporosis. Again, lifestyle factors, it's never too early to start thinking about it. And finally, I did mention also maintaining a healthy weight can have a significant impact. Work closely with your provider because we want to make sure that we are targeting screening and treatment options to people at the appropriate time. So I want to make sure that I leave some time for questions, but thank you so much again for inviting me to speak.
Thank you, Amber. I'm going to introduce Larry real quick, and everybody else can pop on their video because we're going to start the panel. So joining the two speakers is Larry Cushy. He's Director of Scientific Policy at the Kaiser Permanente Northern California Division of Research, and he leads the Pathways study. So please continue to put your questions in the Q&A. We have gotten a ton of really great questions. So we're not going to be able to get to all of them today, so I'll apologize in advance for that. Let me see if I can pull them up. So let's see. Let me start off by asking, let's see. Dr. Wheeler, I don't think you answered if one calcium supplement's better than the other.
So perfect. That's a great question. So between calcium carbonate and calcium citrate, most of the time we recommend doing calcium carbonate. The reason why I like calcium carbonate is that each tablet actually has a higher amount of active calcium or elemental calcium. So typically with calcium carbonate, you actually need to take less supplements to actually get the daily recommended amount. However, there may be some situations where calcium citrate may be more appropriate. These are for patients who there may be difficulties with absorbing calcium through their gut. So this may be patients who have had a history of bariatric surgery, or maybe on proton pump inhibitors for acid reflux, or have any GI conditions where they may not absorb things as well through their gut, such as celiac. So for most patients in the general population, I recommend doing calcium carbonate for that reason, but calcium citrate may be appropriate in these situations.
Great. Thank you, Amber. So regarding calcium-rich foods like yogurt, should people be concerned about their contribution to inflammation? And what about non-fat Greek yogurt?
All right. So non-fat Greek yogurt, excellent source of calcium, also an excellent source of protein. And so I know that there's a lot of discussion about inflammation and also maybe dairy products. So I know that many patients may want to stay away from animal-based protein if they're concerned about inflammation. So this may be something where you may want to try to focus on getting your calcium sources maybe from non-animal-based protein. However, the calcium is so important and the risk of fracture is important. So the risk of inflammation I would think, is very minimal with yogurt and these calcium-rich products. So I absolutely do still endorse getting calcium from products such as yogurt. So I don't think the contribution to inflammation is significant enough where I would eliminate dairy products from people's diet.
Yeah, I'll just add in and basically say that it's the slide that Amber showed of calcium sources. There were these non-animal sources, and green leafy vegetables actually have pretty high fractional calcium absorption, are reasonable calcium sources, obviously not as concentrated as dairy products. And there's some others, certainly, in recent decades, I guess, or so, orange juice, for example, you can get a calcium fortified version of orange juice and that type of thing. So
We had a question. Can you give any guidance for those with breast cancer patients and survivors who were diagnosed under 40? So when should they get a baseline bone density test?
So for most most of the breast cancer patients who are going through breast cancer treatment will often do a bone density at the start of treatment, just to document where the baseline bone density is. I know it may be difficult especially with the history of breast cancer, some patients may not qualify to consider estrogen-based therapies. So it may be difficult to correct the estrogen deficiency to try to slow down the bone loss. However, we start with the baseline bone density, and then we monitor closely over time to see what the trend is and the bone density changes over time. We may initiate treatment a little bit earlier if patients are developing osteoporosis at an earlier age, but oftentimes we work to optimize all the things that we talked about, the calcium, the vitamin D, the weight-bearing activities, just to try to mitigate the effects of different treatments on bone health in general. But I know it can be really tricky when women are getting treatments much earlier, and that may have some effect on bone density and maintaining bone density at an earlier age.
Now, we had some questions on bone building drugs, and I think your presentation got cut off a little bit before you could share all of the information there, if you want to go back to that thought.
Yes. So with the two categories of medications between bone building agents and also bone, like slowing down a bone loss, the anti-resorptive agents, not all, especially with some of our breast cancer, especially with some breast cancer treatments, not everybody is an ideal candidate actually for some of the bone building agents, unfortunately. Many women will get radiation treatment to their chest wall as part of their breast cancer treatment. And for women who have had exposure to radiation treatment, it actually is a contraindication to using any of the bone building agents, because some of the risk of the medication may put you at risk of developing something called osteosarcoma, which is a bone cancer that we're, of course, trying to avoid people from developing. We may use it in some rare instances, but for the most part, the bone building agents can be not indicated based on what treatments you get for your breast cancer. For women who haven't gotten chest wall radiation, usually we look at the bone density to help guide us to see who may be a good candidate for a bone building agent versus just an anti-resorptive agent. They typically work best at the spine. So if people have really low bone density at the lumbar spine, that's where we're going to see the most impact from the bone building agents. So those are the patients we're going to want to channel those agents to primarily, because again, we want to see if we can build the bone at an earlier stage rather than trying to build it up later when there may be a risk of fracture or they've gotten other treatments. So we always want to think earlier on about if people are appropriate candidates for the bone building agents.
Thank you. Marilyn, the polygenic risk score was something that was mentioned in the update to the FRAX test, and I know you've done research related to that wasn't shared today. Can you describe anything related to how that research might inform the update to the FRAX test or screen?
Yes. So yeah, we did do some genetic work developing a polygenic risk score describing one's possible risk of experiencing osteoporosis and fractures. And I don't recall the details, but in general, and we can place the link in the chat for those out there who are interested in learning more. But in general, we did find some specific genetic profiles that were potentially related to the overall risk of developing a fracture after AI therapy. So our plan is to test the contribution of that PGS, the polygenic score, in our proposed BC Fracs prediction model.
Great, thank you. And we have some questions about breast cancer and whether survivors with osteoporosis are at a greater risk for recurrence.
I'm sorry, but osteoporosis, or I'm sorry, can we, I wanted to get a little more information about that because there's a question about recurrence versus osteoporosis. So the question is, are patients who have osteoporosis at increased risk of recurrence? So what's interesting actually is that depending on the breast cancer treatment that you get, oftentimes osteoporosis treatments are actually a big part of the treatment course for breast cancer. So some patients are treated with Zometa, one of these osteoporosis medications, every 6 months. And this is trying to either to lower the risk of breast cancer metastasizing to bone, or we also use these medications for women who do have breast cancer involvement in their bone to keep their bone strong and also try to kind of subdue the breast cancer at that spot. So osteoporosis agents are also very strongly incorporated into breast cancer treatment, like regimens as well too.
Yeah, we had some questions about how metastatic breast cancer in the bone is impacted by these treatments. Like, how does osteoporosis relate to mets in the bone?
So we often will use these medications regardless of whether people have osteoporosis or not. So the medications are used for a variety of reasons. They want to stabilize the bone to prevent risk of fracture relating to the metastasis. Also, when the cancer is incorporating into the bone, many people can get a lot of release of calcium out into their bloodstream. So it's also trying to keep their calcium levels low and to try to prevent that from causing additional illness and sickness too. Also, we're trying to contain the cancer in that part of the bone as well. And there is a lot of good data showing that the treatments are actually beneficial for bone health in patients with metastatic breast cancer.
Great, thank you. So someone says that their oncologist doesn't recommend a DEXA scan or osteoporosis screening because they're considering tamoxifen instead of an AI. But they're wondering, why wouldn't their oncologist want a baseline if is it about overscreening and unneeded treatments?
That's a good question. So tamoxifen is definitely associated with much less bone loss versus an aromatase inhibitor such as anastrozole or Arimidex. So we don't tend to see the same bone density changes with tamoxifen. So that's why I actually love it as a first-line treatment if patients are good candidates for it. We're not expecting to see it, but I do think that at times it's reasonable just to make sure that the bone density is staying stable over time. There could be other factors beyond just the treatments that can place people at risk of developing osteoporosis. However, for people who are very young, the risk of fracture is actually exceedingly low. So that's when the FRAX score actually is very helpful when we're trying to figure out how likely is it that someone's actually going to have a fracture with all of their individual information. So I like using the FRAX score to help me with bone density screening for patients who are low risk for fracture. Because we're using DEXA and all these bone mineral density measurements to help us to get some information for what might be the fracture risk and what can we do to lower the risk of fracture in the future. But we know that the BMD is just a number, so even for people who may have lower bone density, when they're young, that may mean their fracture risk is still quite low. So it can be very confusing on what to do with these bone densities for younger patients who are low risk of fracture, even if their bone density is a little bit on the lower side. So that may be why your oncologist may not be recommending doing a bone density, because your risk of fracture is quite low and you're on a treatment that is not associated with significant bone loss over time.
Thanks. So if somebody has osteoporosis, what's the benefit of a DEXA scan if they're not interested in bone meds?
I usually use it as a measurement, because even for many of my patients who aren't interested in treatment, there may come a time where they may be seeing the changes in bone density over time, where they may actually change their mind. So it can be also just for monitoring. And for me, I want you to have all the information. If I'm making a treatment recommendation to you and you're not quite ready for that treatment, I still think it's important to keep track of what's happening with your bones and how they're changing over time. I've had many patients who, when they were younger, were not interested in having a treatment. However, as they got older and they saw the bone density progressively declining with time, they may have changed their mind and opted to have the treatment as well. What's also hard is that, for me, bone density and trying to preserve your bone density, it's all about your independence. So as people get older and their risk of fracture goes up, many patients who have had a hip fracture, about 40% of patients 1 year after fracture are still not walking as well independently as they were before they had their fracture. And also, as people get older, their risk of death from a hip fracture, it substantially increases with time. So as people get older, I really want you to be able to live a really happy and independent life. And if having a fracture really takes away from that independence, I want to offer you everything I can to keep your risk of having a fracture as low as possible.
Thank you. Someone's wondering about K2.
So the K vitamins are often implicated with bone health. There's K1 and there's also K2. K1 usually comes from a lot of the dark leafy green vegetables, and K2 comes from other food sources like natto and other foods. A lot of the research is showing that K2 can be an important part of helping to absorb calcium and vitamin D from the diet, and also just preserving bone health. There's not official guidelines in terms of what's a healthy amount of K2 to take in per day. Also, there's no evidence showing that using K2 actually decreases your risk of having a fracture.
Right.
That being said, if you have opportunities to increase your K2 intake from your diet, I absolutely recommend it. However, I don't think it should take the place of a lot of our our calcium and vitamin D treatment, and also our recommendations for osteoporosis medications at the appropriate time.
Thanks. Someone's wondering where they can get the FRAX screening.
So I was just replying to this one. So FRAX is actually included on every bone density report. So I hit it on my particular slide with the DEXA report, but it actually is reported directly there. Also, if you Google FRAX, there's a website out of Sheffield, UK, and you can actually calculate your FRAX score online. And the nice part about doing the FRAX is that you actually don't need a bone density to calculate your FRAX score. So you can take a lot of your the risk factors for developing osteoporosis and punch them into it, and you actually don't need a bone density to calculate your risk. Another caveat, though, to using FRAX is that if you've gotten a treatment for osteoporosis, such as Zometa, as part of your breast cancer treatment, the FRAX score actually, you can't use it anymore. So getting a treatment for osteoporosis, the FRAX score is not intended for people who have been treated before in the past.
Thank you. And then we had a question about vitamin D versus vitamin D3.
So vitamin D comes in multiple forms. So vitamin D2 is more plant-based, so that's your ergocalciferol, versus vitamin D3, which is cholecalciferol. Most typical is that when we have patients who have more severe vitamin D deficiency, we use ergocalciferol, since it comes in kind of higher quantity, to kind of very rapidly bring up the vitamin D levels. So very frequently for people with lower vitamin D levels, I may give them ergocalciferol 50,000 units once a week for about a 6-week course to really rapidly bring up their vitamin D levels. Then I use cholecalciferol or vitamin D3 as a maintenance therapy. So this is one where you're taking it every day to help to maintain that vitamin D level. So I think that depending on where you're starting from, ergo could be a good treatment option to bring things up quickly versus using the D3 as a maintenance.
Great, thank you. So we are just about at time, and I want to make sure that everyone knows that there's a survey after this webinar, and you'll receive a follow-up email with a link to the survey and recording. and our next webinar will be in fall 2025. Amber, did you have to hop off, or do you have a couple more minutes?
I might have a few more minutes, and I'm hoping that I can put this in the chat. I think some people asked some questions about yoga. I know we're not supposed to do links, but
Oh,
there's
no,
a
you can do links.
there's a great
Please.
link. There's actually a great article published by the Mayo Clinic where they actually looked at the different yoga poses and which ones are actually okay for twisting for people with osteoporosis versus those that should be avoided. I put a picture of the ones that should be avoided in the talk. However, they, like there's certain ones like warrior pose I get questions about a lot because it does have a little bit of twisting involved. Warrior pose was not associated with higher risk of fracture, but many of the headstands or the ones where there's direct bending at the back versus at the waist were not recommended. Again, a lot of the yoga instructors are very well versed in how to modify a lot of the positions and poses for patients with osteoporosis. So I would definitely mention your bone health to the instructor if you have any questions about what's appropriate for you.
Thanks. Someone's wondering why they can initially be on Fosamax for only 5 years, and they're on their second 5-year round. Is that safe?
Yes. So we do courses of Fosamax usually in 3 to 5 year courses, and then we want to give people breaks from these medications. So what we saw is that the most fracture reduction benefit is usually using these medications for about a 5-year course. And after a while, though, the medications like Fosamax, they slow down a lot of your bone dynamics. So we want old bone to get chewed away, and we want new bone to get laid down. And the way that the medication works is that to slow down bone loss, it kind of freezes the bone in time. So we want to give patients breaks from the medication so that those normal dynamics can come back again, and we can improve the quality of the bone that's there. However, for people who are on these medications more than 5 years, we think that maybe the bone might become a little more fragile with time because of the effects of the medication. And for many patients who have been treated continuously, especially for 10 years or more, may be at risk of actually having a fracture due to the medication. So we really went back to the drawing board and started to change up how we were using these medications for treatment. And what we found is that if we give people a 5-year course, give them a break, monitor their bone density, and we can always retreat later down the road in the event that they're having bone loss again and could benefit from the treatment.
Thank you. Can you say more about why a FRAX score is not useful for people who've gotten Zometa infusions? This person had them for 3 years, and they want to know if that means the DEXA scores and fracture risks are not meaningful.
So the DEXA is actually still helpful. And so you can still use things like the bone mineral density and also your T-scores off of the DEXA report. However, the way that FRAX was created was that it was created using people who had been treatment naive or had never been treated for osteoporosis. So what we see is that the FRAX score may overestimate your risk of having a fracture if you've had a treatment for osteoporosis in the past. So that's why we don't recommend using it for people who've been treated before, because the FRAX score may recommend treatment based on your 10-year risk, but it may be overestimating your 10-year risk. So that's why we don't use it. We're not saying it's not helpful. I look at them still, but I often am very reserved in making treatment recommendations based on FRAX for somebody who's been treated before.
Can osteoporosis or osteopenia actually be reversed, or is it just maintaining bone?
So that's a great question. So depending on which treatment you're using for osteoporosis or osteopenia, it depends on which agents we're using. So for the medications or the anti-resorptive agents, since we're working to maintain bone density, we're expecting to see a stabilization of the bone density. That's the goal of therapy with those. So what we can actually see is you still get the fracture reduction, even if there's no change in your bone density on the DEXA. So you still see that 40 to 60% reduction, even if the bone density remains stable. Sometimes for patients who are on treatments like Zometa or Fosamax, we can see some improvement in the bone density while they're on treatment, but I usually tell patients that's not always the expectation. The expectation is really for stability. However, if you're a good candidate for one of these bone building agents, you actually can see some improvement in your bone mineral density while you're on treatment. So it depends on which agent you're going on, and also depends on what your bone density looks like at the time where we're making treatment recommendations.
Thanks. Someone's wondering about Fortero for osteoporosis, and if you can discuss this newer option.
Yeah, so Forteo is one of the bone building agents. I didn't mention them by name, but that is one of the agents. So Forteo, it's a daily injection that you give yourself over the course of about 18 to 24 months. And this is involved with bone building. As I mentioned before, Forteo is one of the medications that if you've had any radiation treatment to your chest wall, you're not an ideal candidate for the medication. So we don't always offer it to patients with that who have ever had that treatment. Second is that we look at your bone mineral density. Since it's preferentially working at the spine, we offer it to patients who have either severe osteoporosis at the spine or have a very low bone density there. So severe osteoporosis or also a history of compression fracture. These are the patients that we see that it's most helpful in because they're already starting at either compromised bone mineral density, and we want to try to build the density at that site. However, the effects at the hip are very modest. So if you have osteoporosis both at the spine and at the hip, the Forteo doesn't have as much of an effect at the hip site. So essentially your hip is not getting it may not be getting enough treatment, or you may not be lowering your risk of having a hip fracture if you're on Forteo alone. So that's why I think it's really important to have that bone density. And also it may be recommended based on the pattern of your bone density or your bone loss.
Thank you. Maybe we can just ask one more to, I know Amber does have patient matters to attend to, so I don't want to keep you too long. Someone's taking Fosamax and getting heartburn, but then taking Prilosec, and they're wondering if that defeats the purpose of the Fosamax.
So I would recommend actually touching base with your doctor if you're having heartburn from the Fosamax. So esophagitis or acid reflux is actually a side effect of Fosamax. So in the event that I have patients who develop heartburn, I actually may switch them over to the IV version, such as Reclast or Zometa, or similar to Zometa, because that is actually a side effect of the medication.
Great. Well, thank you everyone for joining us today. This has been lots of great information, and please feel free to reach out if you'd like a follow-up question I mean, we get so many questions and they're all a little bit jumbled together. So I apologize if we missed yours. Please feel free to reach out if you still have one, and we will get back to you. So I'm going to end this webinar now, and I hope to see everybody again when we have a webinar in the fall. All right, thanks, bye.